Hello, everyone. Welcome to today's webinar, Congenital Syphilis in Maine, Prevention Equals Cure. Today's speakers will include myself, Dr. Catherine Hsu. I have a joint appointment between the Massachusetts Department of Public Health and the Boston University Medical Center. Lieutenant Commander Dina Bushman, nurse practitioner, career epidemiology field officer assigned to the Maine CDC. Emily Kaysen, STD HIV surveillance epidemiologist with the Maine CDC, and Marissa Paul, Associate Program Manager, Disease Intervention Specialist, Maine CDC. Today's webinar has been jointly sponsored by the Rotel STD HIV Prevention Training Center of New England, a project of the Massachusetts Department of Public Health funded by the Centers for Disease Control and Prevention, as well as the Maine Department of Health and Human Services, Maine CDC. In the past 12 months, none of the faculty have had relevant financial relationships, and we do not intend to discuss an unapproved or investigative use of any commercial products or devices in our presentation today related to this CME activity. Continuing education credits are available for this learning activity. After the program, participants will receive an email with a link to complete a short evaluation. Upon completion of evaluation, CE certificates will be emailed to you. Today's webinar is being recorded, and after the program, you will also receive an email with a link to the recording. Please feel free to enter questions in Zoom chat. We will answer as many as possible at the end of today's presentation. The objectives for today's presentation are to review syphilis testing recommendations and epidemiology in Maine, primarily focused on prevention of congenital syphilis, review syphilis presentations in natural history, apply syphilis diagnostic testing algorithms and interpret testing results, and review stage-specific syphilis treatment and management, as it is in 2023. We will also provide some additional clinical and public health resources at the very end. Let me pass the microphone to Dina Bushman next.
Thanks so much, and thank you all for joining us. So there are numerous challenges to testing, diagnosing, and treating syphilis, especially during pregnancy, which we want to quickly highlight in this case study, which actually occurred here in Maine earlier this year. Next slide. Next slide. This is a woman in her early 20s seen at the emergency department to confirm her pregnancy. During this time, she complained also of rashes across her chest. However, no syphilis testing was ordered. Next slide. During her first OB appointment, she asked about the rash, which had persisted, but per our record review, no syphilis testing was ordered. Furthermore, despite the US CDC STI treatment guidance and Maine law, no first trimester screening testing was ordered due to a data entry error. Next slide. During her OB care, the patient reported multiple risk factors for syphilis, including sex trafficking and drug use, and she unfortunately still was not tested during the third trimester or at delivery. She went on to deliver twins, who at this time are about 1 year of age, and who were at the time having multiple health issues consistent with congenital syphilis, including but not limited to multiple skeletal abnormalities and fractures, and had been referred to numerous specialists, none of whom had congenital syphilis on their differential. The twins were actually taken by their mother and placed in foster care, as it was thought that the fractures were results of child abuse. Next slide. Many months after delivering her twins, she went on to donate plasma, and as part of their screening process, she was tested for syphilis, which was positive. After she was diagnosed, one of our disease intervention specialists, who you will meet later today, was able to speak with the pediatrician caring for the twins and encouraged him to test the twins, both of whom then tested positive. Both of the twins were referred to pediatric infectious disease and were treated for congenital syphilis and are now back at home with their mother. Next slide. So when we think about congenital syphilis, we think about missed prevention opportunities among persons delivering babies with congenital syphilis, which can usually be classified into 3 categories. So the first one is no timely prenatal care, no syphilis testing, and timely syphilis testing, but not adequately treated. And by adequate treatment, we mean the completion of a penicillin-based regimen, which Dr. Shu will go over later in the presentation, in accordance with CDC treatment guidance, appropriate for the stage of infection, initiated 30 days or more before delivery. Adequate and timely treatment of syphilis in pregnant persons is 98% effective in preventing congenital syphilis. Next slide. So who should be tested for syphilis and when? Healthcare providers in Maine are required by law and with patient consent to test for syphilis at least once during pregnancy. Next slide. Here at Maine CDC, we also recommend testing all people whenever they present for care, including at emergency departments, jails, and substance use disorder treatment facilities, and also testing people at high risk for syphilis regardless of known pregnancy status. And US CDC also recommends testing asymptomatic women who are at high risk and all pregnant persons at least once during pregnancy, ideally at that first prenatal visit, and testing again at 28 weeks and at delivery if at high risk. There's a link here to who is at high risk, which is also laid out on the next slide, which includes pregnant persons who misuse drugs, exchange money or good for sex, who are unhoused, have a history of STI during pregnancy, multiple sex partners, a new partner or partner with an STI, who live in a community with high syphilis morbidity, have a delayed or no prenatal care, and had a positive syphilis test in the first trimester. I'm now going to pass the microphone over to my colleague, Emily. Thank you.
Thank you. Next slide, please. So moving into the epidemiology, cases of syphilis in Maine, unfortunately, have increased over 500% from 2013 through 2022, with 17 cases reported in 2013 and 112 reported in 2022. The decrease you see in 2020 was likely a result of underdiagnosis during the COVID-19 pandemic, as patients were less likely to access medical services. Next slide, please. In Maine, the percentage of syphilis cases among women is increasing, and in 2022, nearly a quarter of the cases of syphilis were women. Next slide, please. In 2022, most of the cases of syphilis among women, as seen in the orange in this graph here, were in women of reproductive age, which includes the ages 15 to 44 years, as noted in the red square. Next slide. And since 2022, 5 cases of congenital syphilis have been reported to Maine CDC. Prior to 2022, the last reported case was born in 1995. And of note, nationally, there has been a more than 200% increase in congenital syphilis from 2017 through 2022. And now I'll pass it back to Dr. Shu.
Thanks, Emily. This places us in a context where there has been an increasing need for clinicians to have right in their toolbox certain treatment, management, syphilis clinical pearls. The key resides in putting maximal effort into identifying and managing complicated patients, because titers are only one piece of the puzzle. In terms of syphilis natural history, one thing we all learned was, and this hasn't changed over the decades, that exposure can happen, acquisition comes in, and an incubation period is approximately 3 to 4 weeks. However, there is an extremely large range to this. This may be the average time of incubation, but the range is 3 to 90 days. 30 to 50% of individuals following exposure to an infectious case of syphilis will go on to potentially display symptoms of primary, secondary, and then potentially tertiary if left untreated. The range for each one of these time to development symptoms is usually on the order of weeks, but can be months for the outer end of the range. After 2 to 8 weeks, for example, lesions of secondary syphilis can disappear, but yet spontaneously reappear throughout the course of a year, range up to 1 year. 2 to 20 years later, 30% of untreated individuals go on to tertiary complications of syphilis. What we've also learned over the decades in managing syphilis patients is that overlap occurs between primary and secondary cases. And at any point at which you become spiroketemic from this particular bacteria, once the bacteria disseminate in the bloodstream, if they hit the central nervous system, the eyes or the ears, neurosyphilis can occur at any stage during this process. The most dreaded consequences, more rapid progression or severe disease, were actually well described in the 80s. Multiple deep ulcers, simultaneous primary and secondary manifestations, Louis maligna, neurologic involvement occurring at any stage, were mostly described in HIV-infected persons with advanced immunosuppression, which we seldom see in this decade, but can still happen. For that initial stage of primary syphilis, individual chancres can take multiple forms, depending on the part of the body that they're identified on. The dogma was always that a primary chancre was a painless ulceration that could develop. But we have also learned over time that some individuals have co-infection with other surface bacteria or other STIs like herpes or monkeypox. And these lesions can in fact be either painful or painless, depending on the context. Moreover, in the digital age, many of our patients take serial pictures of the presentation of an ulceration that may initially develop as a discoloration, progress onto thinning of the skin, and then ulceration, and then eventual healing. And with those time-stamped lesion pictures, what you're seeing displayed in this graphic may not always be the canonical way you see a primary chancre on the front lines in clinical care. Nevertheless, it's still useful to know that chancres can look like this on the shaft of the penis. They can be multiple. They are not always single. They can appear wherever the exposure and the portal of entry originally occurred, in this case, around the mouth or the tongue, or the final picture is between the digit, the great toe and the second toe of a commercial sex worker back in the 80s. Secondary syphilis can also have myriad presentations, particularly in terms of the rash. The rash is pleomorphic, easily confused with other rashes that can take place from viral illnesses, other bacterial illnesses, or even rashes that can take place during pregnancy. What is a little bit more unusual and particular to syphilis, but does not always happen in every patient who has secondary syphilis, is the appearance of the rash on the palms and soles. And here you again see two examples. The rash can be flat. The rash can be raised. It can have scale. It may not have scale. And again, can be confused with other presentations such as acute HIV. Sometimes the rash is itchy. Sometimes it isn't. Other manifestations of secondary syphilis include condyloma lata, which can look like warts, but tend to be wetter in appearance and are highly infectious. Staining done on swabs of this particular genital lesion, for example, have demonstrated numerous spirochetes of the bacteria that causes syphilis. Alopecia as part of the rash appearance on the scalp of an individual can look like this. So hair loss can also happen. We still make the diagnosis of syphilis not only based on clinical presentation, which again does not happen in every patient, but primarily based on serologic test reactivity. And this graphic comes from Rosanna Peeling's summary that was published years ago in the Bulletin of the World Health Organization, and simply summarizes, following acquisition of infection, the surge in antibody production occurs over the course of weeks, is detectable by about 90 days if you have in fact acquired the infection, in parallel to some of the clinical manifestations shown on the bottom part of this graph, clinical stages. Left untreated, syphilis infection for treponemal antibodies can persist. Treated or untreated, the treponemal antibody stays positive. We'll review that on the next slide. The non-treponemal antibodies, when an individual is left untreated, may not stay persistently positive. So serologic reactivity is always interpreted in the context of history, prior clinical findings, and clinical treatment. This testing for syphilis, when we make the diagnosis, requires the detection of two types of antibodies. Non-treponemal antibodies, which are nothing more and nothing less than antibodies directed against lipoidal antigens, many of which mimic human surface antigens. So RPRs and VDRLs are example of non-treponemal antibodies. Treponemal antibodies are somewhat more specific to T. pallidum, the bacterium, the spirochete that causes syphilis, and the proteins that we mount a defense against. And these tests include things such as the TPPA, the MHA-TP, fluorescent treponemal antibody absorb assays, enzyme immunoassays as part of the reverse sequence algorithm, and some of the other ones listed on this slide. As with any serologic test, though, multiple other agents can in fact cause cross-reactivity and false positives. So for the non-treponemal tests, viral infections, other viruses such as infectious mononucleosis, hepatitis, varicella, measles, other bacterial diseases such as TB, or parasitic infections such as malaria, or autoimmune diseases can cause false positive RPRs or VDRLs, the non-treponemal tests. In terms of treponemal tests, although we do find them to be more specific to T. pallidum, other spirochetal illnesses can also cause cross-reactivity. That in a state and a clinical context where a dual TREP and non-TREP antibody are identified as positive, in effect, most clinicians move forward with syphilis treatment if the patient has no prior history of prior treatment. Probably the best summary list of agents that can cause cross-reactivity with these different types of serologic tests is found in the American Academy of Pediatrics Red Book for Pediatric Infectious Diseases. These syphilis tests have been around for decades and traditionally are done manually. One thing that has changed over time is that many laboratories in hospital settings or larger commercial labs or larger state labs have identified automated test platforms to read out the quantity of antibody detectable. Finally, rapid syphilis tests have also been developed. Regardless of the category, syphilis testing still remains a diagnosis done by serology. We do not have a direct test for the organism itself that is clinically available for testing and diagnosis. When we go to interpret the titers, despite the fact that the tests are imperfect. One thing we have come to learn is that a drop in the non-treponemal test titers that can be monitored is a wonderful way to monitor for response to treatment. We look for 2 dilution or 4-fold decline following treatment to tell us that somebody has responded to treatment for syphilis. A single dilution decline is unlikely to be statistically significant because the test is so imperfect. So we monitor for 2-fold changes in order to identify either reinfection when the titer goes up or response to treatment when the titer goes down. In fact, we know serologic titers are so reactive, especially in early syphilis. A recent publication of Australia, in fact, highlighted changes in multiple significant dilutions, at least 2 dilutions or even higher, even on the order of days apart if 2 measurements were done. So it is important to check day of treatment titers to provide the best baseline for management. Many times, the history of prior syphilis titers and treatment is not available to the clinician working with the patient on the front lines that day. However, because syphilis is a nationally notified and jurisdictionally specifically notified disease of public health significance, all public health jurisdictions do maintain surveillance records, and many times consulting with public health for prior titer and treatment history in the United States and in some of our territories can be very helpful for histories. Moving on to treatment, I will point out that as of the 2021 CDC guideline iteration, which is the public health guideline, but also functions as the clinical guidance for clinicians around the United States and beyond, the recommendations for treatment for syphilis over the stages of syphilis we talked about before have not changed. The primary focus remains on a drug that has worked, and this particular bacteria has never been shown to mutate out of penicillin control. For primary and secondary syphilis, acquired and symptomatic within the last year, or if you identify a patient who has a recent infectious contact, a single dose of benzathine penicillin G is sufficient to treat all patients, regardless of immunocompromise or not. For latent syphilis, if you are known to have acquired your infection through a history of sex partnerships with somebody who's recently infectious, within the past year, again, a single dose is effective. But if we are not sure, or the stage is known to be a syphilis infection that was acquired greater than a year ago, latent syphilis, that is treated with 3 doses at 1-week intervals. The recommendation for neurosyphilis or ocular or otosyphilis is for a different dosing level of penicillin in order to achieve treponemal levels within the central nervous system or the eyes or the ears. And that would be for IV penicillin, administered as 3 to 4 million units IV every 4 hours, or continuous infusion for 10 to 14 days. Unfortunately, this laser outlook onto penicillin as our key drug of importance for treatment of syphilis has also resulted in national shortages. And a recent Dear Colleague letter issued by our colleagues at the Centers for Disease Control, Division of STD Prevention, provided some key clinical reminders during a bicillin long-acting shortage. Bicillin is the trade name for benzathine penicillin G, 2.4 million units. This was issued in July 20th, 2023, and I'm going to ask my colleague, Marissa Paul, to comment on what this bicillin shortage has meant, if anything, for Maine.
Thank you. So Maine CDC has received reports of facilities affected by low stock. We continue to monitor this situation closely and are encouraging providers to contact us if their office or clinic is experiencing low stock or stockouts.
Helpful technical assistance across institutions can be done. In terms of the guidelines, which again govern clinical management of syphilis, what we do with RPR titers that don't respond appropriately has been a question that has vexed clinicians through the decades. Because again, the serologic test is imperfect. How long you can wait has become more clearly defined for the extent to which you should expect someone to achieve the fourfold decline in titers following therapy for early syphilis, or you can actually give it up to 24 months following therapy for late syphilis, syphilis acquired greater than a year ago. However, if patients exhibit any neurologic signs and symptoms that are new, in that case, around the time of these deadlines, 1 year for early, 24 months or 2 years for latent syphilis or late syphilis, there is an indication to perform an immediate LP to investigate whether or not the patient could have been reinfected is always reasonable to inquire. But if neither of these is the case, you can either follow the patient carefully at 12 months or 24 months, or you can give additional antibiotics. But several observational studies suggest that there isn't any short or intermediate term benefit to additional antibiotics at this stage. Consultation with an infectious disease specialist more experienced in the clinical management of syphilis is likely also helpful. If there is a fourfold increase in titers after appropriate therapy, once again, thoughts of whether or not there's a hidden pocket of syphilis that did not quite get fully treated by the original levels of administered penicillin, for example, the need to do an LP, crop up again. Could the patient have been reinfected? If yes, treat. If the patient denies the possibility of reinfection and the titer continues to be elevated when repeated 2 weeks later, again, accounting for the inevitable variability in titers, even 1 to 2 dilutions away, we consider it significant if it remains fourfold increased. And in these individuals, we do consider performing an LP if there is a fourfold increase in titers and the patient was not previously treated with neurosyphilis regimens. It is beneficial, now that we are seeing more and more syphilis, to remember that neuroocular otic syphilis actually always occurred with symptoms if a careful screening was done in about 1 to 5% of all secondary syphilis cases. 1 to 5% of secondary syphilis cases are symptomatic with recent new trouble hearing, new ringing in the ears, new change in vision, flashing lights, spots or dots, blurring of vision, new headaches, new confusion, new memory changes, new difficulty concentrating, personality changes, trouble walking, or numbness or weakness in the legs. Use of a screening tool such as this one, published by Seattle King County Public Health County Health Department and in use in many sexual health clinics across the nation, is very useful to be systematic in screening all patients who are identified to have early syphilis or the symptoms of secondary syphilis. Finally, to review, the utility of LP is greatest in individuals who have these new neurologic signs and symptoms, or are diagnosed with signs and symptoms of tertiary syphilis, such as cardiovascular syphilis or GUMAS. We are actually not universally recommended to apply LPs or arrange for LPs in our patients who are asymptomatic, but whose serologic titers increase fourfold, as previously mentioned. after stage-appropriate therapy. There are no data to support routine LP in asymptomatic persons with HIV, and there is no need for a follow-up LP 6 months after the diagnosis and treatment of neurosyphilis in HIV uninfected or persons living with HIV who are on ART if they are improving clinically and their peripheral serologic titers are responding appropriately. We know that it can be difficult to identify the patient who has truly new signs and symptoms, particularly in patients who are older. And a lot of collaborative decision-making goes into these decisions about when to LP. Additional updates specific to the 2021 guidelines include a retraction of prior statements. We used to LP individuals who had only otic or ocular syphilis. Now, if a patient has secondary syphilis but has only ear signs or only eye signs, CSF examination is now known to be normal in 90% of cases or 40% of ocular cases, and is not routinely recommended if the patient only has otic signs and symptoms and, for example, no new onset headaches. In those with true new onset headaches, in addition to these, please go ahead and perform or arrange for an LP. But please do not delay onset of IV penicillin usage, because inevitably, as with all bacterial infections, patients do better with earlier treatment. The LP can always be done within days or a week of starting IV penicillin therapy if that decision to treat with higher levels of penicillin is made. In terms of applying this information directly to pregnancy, what can we learn from prior studies that were done in the 80s when syphilis was actually as common as it is now? Indeed, treatment during pregnancy is a 2-for-1 deal. The only ways to prevent congenital syphilis are to prevent, test, and treat maternal syphilis, to prevent transmission across the placenta. This transmission can take place as early as 9 to 10 weeks of gestation, but can occur at any stage of pregnancy or via a lesion present at delivery. The rate is dependent on the stage of syphilis in the pregnant individual. Primary or secondary syphilis is 60 to 100% of the time transmissible even across placentas, which can often defend against some infections. Late latent syphilis, probably the numbers are statistically much less likely to transmit syphilis. The spirochetal burden in the pregnant individual is less. So we believe it runs at about 13% transmission or less. Untreated syphilis during pregnancy, unfortunately, can lead to spontaneous abortion, stillbirth, or perinatal death in 40% of pregnancies. So in effect, we never leave a pregnant individual untreated. You just don't have that option to take that kind of chance. In terms of clinical features, many of the ones that we just reviewed for general syphilis are in fact true for pregnant women and for pregnant individuals in general. Pregnancy has little effect on the course of syphilis, but syphilis has a major impact on the course and outcome of pregnancy: abortion and stillbirth, preterm delivery, and congenital infection. So for example, in following treponemal test declines, should we expect that the 4-fold titer decline that we look for to document response to therapy will necessarily occur in the 9 months an individual can be pregnant? The answer is no. Unfortunately, they don't speed up the process of serologic responsiveness, nor do they slow down the process of serologic responsiveness. And this was just one study published in the 2010s when we had greater amounts of experience from the Texas cohorts. indicating that the drop-off in titers days from treatment took up to 60, 90 days, particularly for primary and secondary individuals. But fourfold titer drops did not always occur during the course of pregnancy. This was included monitoring thereafter. Entirely stage dependent for the speed with which the drops occurred, and very similar to timelines established by non-pregnant individuals. There are some other key studies to re-examine now that we are being forced to manage and treat women who are experiencing the complications of syphilis during pregnancy, or individuals who are experiencing the complications of pregnancy. These complications can include monitoring, which can be done in 2023, much easier than it used to be done, through the use of ultrasonography. And also just thinking through the speed with which symptoms progress and regress during the course of a pregnant individual's response to syphilis therapy. So here is a graphic display, again from the 2010s, Texas cohorts contributing this information, indicating that amniotic fluid infection, of course, happens first before the fetus is actually infected. Polyhydramnios then regresses. And the timeline to regression of each sign or symptom is different. Abnormal Dopplers actually respond sooner if there is an abnormal one to start with on the initial level 2 ultrasound that needs to be performed. Ascites, polyhydramnios, placentalomegaly, and hepatomegaly take a longer time to regress. And this natural history is clearly documented in some of the studies that were published in the 2010s. There has been no update on the treatment of syphilis during pregnancy. Penicillin is absolutely the treatment of choice for pregnant women. And certain evidence, in fact, indicates that additional therapy is beneficial for pregnant women. So many experts treat primary, secondary, or early latent syphilis acquired in the prior year, with a second dose of benzathine penicillin, 1 week after the initial dose. If anything, we are even stricter, given that the volume of distribution in a pregnant individual for the treatment of syphilis with penicillin, the volume of distribution is greater. Missed doses greater than 9 days apart between doses are not acceptable, and the series needs to be repleted again for late latent syphilis. There is no alternative to the use of penicillin for treatment of syphilis in pregnancy, which then leads to concerns about the need for penicillin desensitization in individuals who are allergic to penicillin, yet are pregnant and deserve treatment for syphilis. For patients with documented penicillin allergy for whom no treatment alternatives exist in published literature, penicillin desensitization can be undertaken with oral courses of therapy that are published from the 80s cohorts, when we had more experience with this. This is just one example of an oral regimen that can be applied even now. But does your patient truly need this? Not if absence of allergy can be documented. And the CDC STI guidelines illustrate a number of ways that this can be done. For example, if a patient may report a distant history of penicillin allergy, but somewhere in the medical record has documented evidence of having been treated with amoxicillin for something else later on in life. It is important to document that there is a true allergy before embarking on this pathway of desensitization, because it may not be necessary. To summarize, non-pregnant versus pregnant individuals with TREP and non-TREP positivity, the way we make the diagnosis of syphilis, the treatment is not that different. Where it varies is the application of perhaps a second dose of benzathine penicillin in a pregnant individual, and the fact that only penicillin is recommended. In terms of people who are non-pregnant, doxycycline is listed as an alternative for those who have a penicillin allergy, for all those who are non-pregnant. Again, emphasizing that there are no differences in management. Screening for neuroocular and otic symptoms also needs to occur in any individual with early syphilis or signs and symptoms of secondary syphilis. Obtaining day of treatment non-treponemal titers also needs to happen. And repeating companion HIV and other STI testing also needs to happen. To not result in delays, the additional things that clinicians think about doing in the second half of pregnancy, if an individual is identified as having infectious syphilis, is counseling to seek obstetric care if fever, contractions, or decrease in fetal movements occurs, and to consider fetal monitoring for several hours after a treatment dose is administered of penicillin. Because the reaction in response to the spirochetes dying from penicillin application could theoretically precipitate preterm labor or fetal distress, but is uncommon. The performance of a level 2 ultrasound in this day and age is also important, but again, should not delay the application of therapy. Once again, keeping in mind the general principle that bacterial infections are inevitably more successfully treated earlier on in the course. The faster the treatment is applied, morbidity is less. The stage-specific frequency with which we follow up individuals in pregnancy varies a little because we always repeat the titer at delivery and compare it to the infant's titer. Non-treponemal titers I'm discussing here. And titers are generally not repeated before 8 weeks post-treatment. Although many people would like to monitor it, it often is not useful to do that if the patient has apparently responded clinically. So really, unless reinfection or treatment failure is suspected, we don't repeat titers before 8 weeks post-treatment, even in pregnant individuals, unless delivery happens in the interim. Despite everyone's best efforts, infant cases may still break through. And I have a few clinical pearls to share for infant management. One comment is to know exactly when you might be more concerned that a failure of penicillin therapy in a pregnant individual may occur. And older studies point us in the direction of thinking about the possibility of failure, which is very rare, less than 1 in 20 individuals, if the higher non-treponemal titers are initially identified at treatment and at delivery. If an earlier maternal stage of syphilis is identified, probably there's a higher treponemal burden. If there's a shorter interval between starting penicillin therapy and delivering the infant, or if the infant is preterm. In these scenarios, the probability of failure of your penicillin treatment to prevent congenital infection is more likely, though still very rare, as illustrated in this particular study published in 2002. One more key clinical pearl to share is that the timing of clinical presentation for infants is not unlike what Dina shared earlier with the case that we started today's discussion with. Many infants who have the exposure around the time of delivery or in the last trimester are in fact asymptomatic at birth. And in 2/3 of untreated cases, in other words, the majority of untreated cases, signs begin to appear in weeks 3 to 8 of life. Nearly all cases have symptoms within that 90-day window if they're going to develop symptoms at all. And the diagnosis can be tremendously delayed until an infant presents weeks later with nonspecific complaints, such as rhinitis, called snuffles in particular for congenital syphilis, pneumonia, or failure to thrive. All very general, all very missable, not specific to syphilis. General principles of evaluation and treatment. The clinical pearl here is that because infants are often asymptomatic, the minimum laboratory evaluation includes an infant non-treponemal test titer to compare to the maternal one at delivery, and that the infant serologic testing must be done on serum, not on cord blood, because cord blood with Wharton's jelly on the umbilical cord can have false positives and also can have false negatives. IV penicillin is generally advised in proven or highly probable congenital syphilis because of higher probabilities of CNS involvement and the need for treponemalcidal titers levels of penicillin in the CNS. And once again, as with pregnant individuals, there are no good evidence-based alternatives to penicillin treatment in congenitally infected infants. In fact, we know that CNS involvement is common in congenital syphilis. The frequency was 22% of infants born to untreated mothers, based on cultures that can be done with a very sophisticated research assay, the CSF rabbit infectivity test. A number of these infants, in fact, would not have been identified any other way because 40% of them had normal physical exams, and about 60% of them didn't have other clinical laboratory or radiographic abnormalities. And even the CSF itself may not show abnormalities in cell count, protein, or glucose. So based on these original research assays published in the 2000s, we now understand the importance of LP in congenital exposure to syphilis. And LP is highly recommended in situations where the pregnant individual did not receive treatment in time. The scenarios under which we describe the evaluation and treatment of neonates born to women with reactive non-TREP and treponemal serologic tests during pregnancy are reviewed in the CDC STI guidelines and the AAP Red Book for pediatric infectious disease management. But there are also new scenarios that describe the management of neonates born to women screened during pregnancy with only treponemal test positivity and a non-reactive non-TREP serologic test, which can occur with some of the newer generation assays when the reverse sequence algorithm is applied instead of starting with a non-TREP titer as the first screen. It just depends on your lab and your diagnostic situation. It's okay either way, but use the guidelines for this additional helpful guidance that was only published in 2021. In sum, the battle to decrease the congenital syphilis rate is waged on 4 fronts: the obstetric, the pediatric, the primary care, and the public health service front. Only by working together can we hope to eradicate congenital syphilis. I'll leave you with a few resources, including the aforementioned CDC STI treatment guidelines, which are a complete misnomer to call them treatment guidelines only. They're actually prevention, screening, counseling, management, and treatment guidelines, and contain a lot of valuable information far beyond syphilis, including changes in chlamydia and gonorrhea management, new drugs for bacterial vaginosis, a new section on Mycoplasma genitalium, and new ideas about when to screen and how to apply old school drugs like metronidazole. If you want to know more about STDs, and today's 1-hour webinar was not enough, there's an app for that, of course, except available now, free, except no competitors, the CDC STI treatment guidelines app for Apple and Android, not your average government product, very useful for looking up drug treatment regimens quickly for STIs, or your friendly neighborhood training center faculty who are experts in STIs. We provide clinical consultation services de-identified within 1 to 5 business days, your choice, to clinicians nationally, but your questions in Maine would be triaged to one of these friendly faces, who you may in fact recognize over time from pinging us with questions. We're just a click away. And this is also now embedded in the treatment guidelines app by the CDC. And many of you in Maine may recognize some of us listed on this slide. Let me pass it over to my colleague, Marissa Paul, to make some additional comments about Maine-specific resources.
Thank you, Dr. Shu. So disease intervention specialists, or DIS, are public health professionals who use contact tracing and case investigation to prevent and control STIs. We are trained counselors, investigators, and educators. So Maine law requires that healthcare providers report some STIs to Maine CDC, and HIV, syphilis, gonorrhea, and chlamydia reports are distributed to DIS for investigation. There are 4 active DIS currently in the state. Kim Meehan Brown oversees York and Cumberland County. Penny Sargent oversees Androscoggin County and surrounding counties, and I oversee Penobscot County, the county and surrounding. And Brenda oversees all new HIV cases in the state. Next slide, please. There are 3 overarching steps in case investigation. Our first step is the treatment call. When we receive a case investigation, we search Health InfoNet or call the ordering provider's office and ask what prompted testing. Did the patient report symptoms or a known exposure? Was a sexual history taken? Did the patient disclose genders of partners, numbers of partners, sites of contact? What other STI testing was done? Did they have extragenital testing? Does the patient have a history of STI testing? And finally, what is the treatment plan? Next, we contact the patient. We sometimes use other methods if we can't reach them directly, such as leaving a callback number with an emergency contact, community partner, or organization like a syringe service program. And during the interview, we review recommendations, such as no sex after treatment, when to repeat testing, and how and why to access treatment if the patient has not been treated. Prevention reminders such as barrier method and safer sex practices. And we can make referrals to pre-exposure prophylaxis, post-exposure prophylaxis, and vaccines. We also ask about partners. Who are your sex and or needle sharing partners? Who have you notified or who needs to be notified of exposure? And this is a voluntary service. We are constantly gauging how the interview is going and how the patient is responding during the interview, and actively prioritize the information that we share during the interview to assess how much we can share before the patient decides to end the conversation. And the final step is partner services. Again, patients can decline partner services. Sharing partner information with DIS is voluntary, but when a patient accepts partner services, they give consent to DIS to confidentially notify partner or partners of exposure, or the DIS will coach the patient on how to disclose the exposure to their partner or partners. Next slide, please. We can be reached directly with the contact information shown here, and requests for consultation can be made by calling the disease reporting line at the 800 number listed below, which is available 24/7, and DIS can be contacted through this consult line as well. I will pass the microphone back to Dr. Shu.
So in summary today, we have reviewed syphilis testing and recommendations in epidemiology specific to Maine, which include a reminder that at least once in pregnancy at the first prenatal visit, and again at 28 weeks and at delivery, if the individual is high risk. We've reviewed some syphilis presentations and natural history without locking ourselves into believing that every patient presents with the canonical appearance of an ulceration or a rash. But the goal is always to identify and treat complications and prevent sequelae, such as central nervous system involvement or congenital syphilis. We have learned and relearned how to apply syphilis diagnostic testing algorithms and interpret testing results in light of titer rise or titer decline. And this always needs to be interpreted in the context of history and exam. Stage-specific treatment and management for syphilis. Many older studies provide details about when to expect treatment response, both through ultrasonographic findings, as well as through regression of non-treponemal test titers in what time event horizon. And we've provided a review of a number of current clinical and public health resources, inclusive of the CDC STI Guidelines app, www.std Clinical Consultation Network, ccn.org, and Maine-specific resources. Are there any questions?
Thanks so much, Dr. Sue and my colleagues, Emily and Marissa. This class was so much great information. Right now, we don't have any questions in the chat, but we do still have a few minutes left. So if anyone has a question, feel free to raise your virtual hand. And if you're willing to come off mute, we'd love to answer questions you might have. Also, you're welcome to turn on your videos so we can see your faces if you're comfortable with that as well. There is one question about sharing the slides to participants. Maybe Dr. Shu or Janine, you guys can speak to that.
Yes, we can. Can you hear me?
Go ahead.
A reminder, continuing education credits are available for this learning activity. You'll get an email with a short evaluation. You'll get the CE certificate. But also, today's webinar was recorded, and after the program, the participants will receive an email with a link to the recording and a static version of our slides. Thank you for the question.
And from the Maine CDC side, we will also post a link on our website linking folks to where those the recording and the slides will be available. We have a question from an FNP student. Syphilis is very prevalent in Bangor. I was wondering if you could recommend routine testing of pregnant women in the last trimester, especially if they've had multiple partners. So I can touch on that because we do have a law here in Maine that states that healthcare providers involved in caring for a pregnant person are to test their patient at least once during pregnancy. And then US CDC and Maine CDC do encourage additional testing at that third trimester and at delivery if the patient is at high risk. Anything else anyone else wants to add on that? If not, we have another question. And I'm happy to direct this towards Emily and maybe Dr. Shu, you can comment as well. Any thoughts on why we are seeing an increase in cases of syphilis and congenital syphilis?
I don't think we can point to just one thing as the reason for increasing cases of syphilis. There are likely many factors. Some of them might be challenges in accessing testing and treatment, lack of prenatal care or lack of testing during pregnancy. There is a fair amount of challenges among our cases of syphilis, such as substance use or homelessness, and all of that contributes to challenges with preventing syphilis and increasing cases.
Thanks, Emily. Anything you want to add, Dr. Sue?
No, I think it's been a challenge and a puzzle to many of us who have been taking care of patients over the years from the sexual health services standpoint. And we're left with many questions and sometimes not as many answers about the epidemiologic rise in the numbers of cases.
Thank you both. There's one last question, and it's about who's at high risk, and I'm happy to put a link in the chat about who's defined as high risk during pregnancy. But in a nutshell, it's an individual who's had a history of syphilis, who has a partner, a recent partner with syphilis or recent diagnosis of STI, who used drugs, misused drugs, experiencing homelessness. So I'm happy to share a link. Oh, it's right there. Thanks. That's also the slide. So I'll hand it back over to you, Dr. Shu, because we are just over time.
Thank you. I think we can go ahead and stop the recording, and if anybody would like to just come off camera and